and welcome to Season 4, Episode 7 of The New Normal. This is Visionaries in Digital Health, driving the transformation of healthcare. On today's episode, we'll be discussing past, present, and future innovations in consumer care and digital health that are transforming healthcare. We host two visionaries and pioneers of digital health who have made a lasting impact on the development of telemedicine, virtual care, cellular technology, and consumer services. Before I introduce our panelists, I want to take a minute and thank you for joining us today, as well as thank our panelists for sharing their time with us this afternoon. As for the structure of the webinar, attendees will be on mute, and we will have reserved time at the end for questions. Please place your questions within the Q&A box, chat. We can review the recordings. You can review the recordings of today's webinar on www.newnormal.buzz. Now to introduce our distinguished panelists. First, Arlene Harris, who will be with us shortly, is co-founder and CEO of Incorporation, LLC. A serial entrepreneur, Arlene Harris was literally born into the wireless business. She invented numerous wireless innovations, including the first over-the-air remotely programmable wireless phones, the first prepaid wireless management system, and is the founder of the Senior Focus Great Call wireless service. Those innovations and others earned Harris the distinction, the First Lady of Wireless. Since the early 1970s, a technology visionary, Martin Cooper, inventor of the first personal cell phone, and Arlene Harris, innovator of successful entrepreneur, have created many first-time products, services, and technologies, enabling an impressive number of new global industries. Cooper and Harris independently, and later in 1986, founded Dyna, LLC, where they incubate and commercialize consumer and enterprise innovations, whether through their own companies or because of the busy businesses they spearheaded. Billions of consumers have been served and untold fortunes that have been made. Welcome, Arlene, when you get on board with us. And then next is Dr. Jay Saunders, CEO of the Global Telemedicine Group. Dr. Saunders is CEO of the Global Telemedicine Group, an adjunct professor of medicine at Johns Hopkins School of Medicine. Is credited with the development of the first statewide telemedicine system, the first correctional telemedicine program, the first telehome care technology called the electronic house call, and the first telemedicine kiosk. His consulting activities included NASA, DoD, HHS, and the FCC state governments, WHO, and multiple academic institutions, and Fortune 500 companies. Dr. Saunders is a graduate of Harvard Medical School, magna cum laude, a member of AOA, and did his residency at Massachusetts General Hospital, where he was chief medical resident. Dr. Saunders has spent the majority of his professional career involved in teaching, patient care, and healthcare research, and has spent over 50 years in the development and implementation of telecommunications and information technology. So welcome, Jay, to the show.
Thank you, Ken. Appreciate it.
So Jay, I'm going to go to you first, right, with this, and kind of give me an outline in your own words of your career around telehealth and telemedicine. I'll bring it out. We discussed it earlier. People do refer to you as the father of telemedicine, even though you don't like sometimes for that reference. But where did it all start with you?
Well, it actually started, if my calculations are correct, about 54 years ago, when I was initially a third-year resident at the Mass General, prior to my being chief resident, when one of my professors, who was constantly having problems with the traffic, believe it or not, the traffic in Boston, going between his outside office and coming to the hospital, and his outside office was only 2.5 miles away from the hospital, he one day came up with the idea of buying 2 black and white TV cameras and putting one in the MGH ER and one at his office, which, by the way, happened to be at Logan Airport Medical Station because he was the medical director at Logan Airport Medical Station. And one day I was running the ER. It was before the days of having emergency medical specialty. So the medical senior resident, surgical senior resident took 12-hour shifts running the ER. I was running the ER that particular day, and Dr. Bird, Dr. Kenneth Bird, who I consider the father of telemedicine, came in and told me his idea and asked me what I thought about it. And I looked at him and I thought to myself, this is the stupidest idea I've ever heard of in my life. But luckily, I had enough common sense to realize I was a resident. He was my professor. And I said, gee, Dr. Bird, that's a very interesting idea. And 2 years later, and I had now become chief resident, we had a total functioning black and white TV system running between Logan Airport and the MGH emergency department. And every single department chairman and every patient took to it like it was something they really liked to do. I guess people viewed it as being on TV. So that's how it started for me.
So, but really quickly, I mean, you didn't have the internet back then, right? To be able to do that. How were you broadcasting? Just over regular RF waves, right? Like TV did?
Microwave. So we had a microwave antenna between the MGH and Logan Airport. And that really was not an issue in Boston in those days. But approximately 4 years later, when I got an NSF grant from the National Science Foundation to try telemedicine, I was at that time assistant chief of medicine at the University of Miami School of Medicine in Dade County, Florida. And Dade County, Florida has the most lightning strikes of any county in the United States. And a microwave antenna transmission does not work well with lightning strikes.
I got you. I can just remember when I was a kid watching, remember Emergency, the TV show that was out there, and they were connected to Rampart General, right? And being able to send vital signs and communicate with people. How real was that back then in the 70s, right? Were they actually, did they actually have wireless technology that was connecting into EDs at that time, or was that all just for show?
No, that was for show. It was predominantly microwave, and then the big dramatic improvement was compression algorithms that we used. But that was it, of course, long before the internet.
So Arlene, welcome. And
I'm so
Jane,
sorry.
that's
I
okay.
can't tell you what I've on a computer. I had to pick up a computer that I haven't used in a while. And of course, in order to get on this call, I had to update and it wanted, well, I'm not going to go through the dilemma. Hi, Dave.
Yeah. Did you guys solve this problem years ago, where it's easier to get on computers and technology and all that kind of stuff that's out there? So
yeah,
it's still a problem today. Well, welcome, Arlene, to this. Similar question I want to ask you a little bit, is where did you get started in all this? How did you move to become the queen of wireless that's out there? What got you started in the wireless and the cellular technology world?
Well, I started early in cellular, or actually in wireless, going way back. My family was in the business in Los Angeles, and we were really innovators in the paging business back in the 70s. Before that, we're in the mobile telephone business. And of course, we were licensed applicants for cellular in 1983. I guess it was 1982. And so it's just been a progression. The actual first services that occurred that were anything like, they were actually the kernel of what it's like today to have wireless in your life. And this goes back to the requirements of industry to provide communications to people like field service workers and others who were in the field. 40 years ago, when a truck came in and picked up its load and left, there was no communications method with that truck until they came back into the lot. So how that translates from paging, which was one of the methods that industry had to connect with their workforce, the field workforce, was the first major enterprise application for wireless. Now, before that, as Jay knows, we had doctors carrying pagers. And they weren't particularly, they really didn't do much more than just beep a doctor and say, you're wanted, and then they'd have to call back to a single point and get their message. So it was really a message, it was like ringing a phone and then hanging up and waiting for someone to call you back.
Do you know what's really interesting? I'm like, why is Arlene going into this level of detail? Because doesn't everybody on this call know what a pager is, right? But you know what? You're right. I mean, it's hard to even get people to go through and go, take this rotary phone and make a phone call on it. They're like, what's a rotary phone, right? From it, right? It's
Right.
amazing how that stuff. Go ahead.
These were the first, so to get technical and not too technical, but pagers were the first tool that miniaturized the delivery of a connection between people that were roaming around and their home base. So that technology from let me just say this, there were pagers during the 60s that were what they called tone and voice. You couldn't serve very many people because of the way the spectrum was allocated. But in the 70s, the high speed, or what then was high speed, today it sounds ridiculous, but you could page a lot of people on one channel. And so that was the business that my family was able to succeed in. It created the largest paging operation in the world in a single city. So, and that was LA. So when the method that we use in both marketing and operations that we use to do that became the catalyst for my career going on into cellular and beyond. So that's why I say that whole area of history is pretty unknown to probably most of your audience.
Yeah.
And let me underline, throughout the 60s, when I was a house officer, I carried a pager. And when there was a code blue, the multiple pagers went off to alert the code blue team to let them know that there was a code blue.
Sure.
Wow. It sounds like some of this underlying technology, did it ever creep in to become eventually SMS and text messaging, right, from that out there? Or does that have anything to do with it whatsoever on those channels or single channels?
Right. Not long before cellular came about, let me think, probably within a few years, one way or the other, alphanumeric paging became a service. What that was one-way dispatch. And that would allow a customer to, let me think, they could call somebody and dispatcher and give them a message, and that message would be transcribed and sent over the air.
Right.
I don't think there were, now that I think about it, I don't think back then there were any direct inputs from consumers trying to send a message to consumers. So it's probably not like text messaging per se, because it had to be supported through that process by operator assistants. I don't, not too long after that, there was a program that was done by SkyTel that was two-way paging. And that was going to be, because I'll tell you, one of the worst things about the original one-way paging is you couldn't get an ACK, and a lot of those acknowledgement back, you know, just a ping back telling you that that was delivered. Like you do today in your text messages, you get a little ping. There was nothing, and so a lot of people would ignore their beeps or whatever you sent them. So it was a acknowledgement loop that didn't exist, and that service came about right at the time that cellular was launching. So it was kind of like there was a nationwide network of two-way paging, and the old paging companies like ours that that sooner or later in the next 5 to 8 years, people were going to be buying cellular phones. 10 years.
So Jay, really quickly on this, I mean, Arlene laid out really well how, well, you started off with, black and white TVs were put point to point between Logan and Mass General, and you put TV cameras with it using a microwave. Arlene's articulated how, you use pagers, one-way paging, and eventually text paging and stuff. Where did telemedicine really start to get its hold? I remember, and you maybe remember before this, by the first health buddy out there was Steve Brown, right, and stuff. But, who were the early innovators in really trying to talk to devices and, going over internet or cellular or, dial-up access, POTS lines that are out there? That's where a lot of it started, right? Where was the evolution there?
Well, people talk about telemedicine today in a very generic way, and they talk about using the telephone.
Yeah.
And listen, I remember when I was a kid, and if I got sick, my mom used the phone to call the doctor, who answered that phone, gave her advice as to what to do. We never called it telemedicine, but for some crazy reason, people today view simply the telephone advice as telemedicine. I don't really do that. I consider an audio video interchange much more effective, and I've always considered that more telemedicine than simply the telephone. Now, I'm sure there are going to be a whole bunch of CEOs out there, including Michael Gordon, who will disagree with me, but fundamentally, we could have called it telemedicine when I was 9 years old and my mother used to call the doctor on the phone. For me, the introduction of video compression technology allowed us to do fairly effective telemedicine in the early 70s. Part of my NSF grant from 1973 to 1976 was using video compression as well as microwave antennas 15 years later, when I set up the state of Georgia system, we used T1 lines that were put in by then Bell Atlantic, Georgia, prior to Verizon buying them.
Well,
So
I
Arlene,
have to
go ahead,
chime
Arlene.
in here, Kent.
Yep.
When I first met Jay, a long time ago, not that long ago, but sometime early 90s, I think, one of the things that was top of his mind about this telemedicine thing is, as he described, you could call your doctor, or maybe the doctor would come out and give you a shot or whatever. You could do that in the 50s and the 60s and the 70s. But I remember his campaign was about, you can't do any of this stuff for doctors can't do these things and be compensated for them cross state lines, you know, whatever they're doing.
Yep.
There was so much regulation and I don't know what you call it, friction.
Licensure, yeah.
Friction of having a doctor be allowed to do his work in any kind of interactive way. Maybe you had to talk to somebody far off, but I remember that was really a point of contention that Jay was working very hard to tear down.
Well,
Am I got that right,
yeah,
Jay?
tongue in cheek. I wish I had thought of starting a pandemic a long time ago.
I get it. I get it.
That
Now
changed everything.
now the conspiracy theory people will be coming in, but go ahead. Right, Jay? That's great.
Yeah, no, I mean, fundamentally, everything that Arlene just underlined was exactly correct. We had the technology. Remember, this was even before the internet. It was
Yep.
DARPANET. We finally got the internet, and Marty's brilliant invention of the cell phone. It made everything possible for telemedicine. There was only one thing wrong. The federal government wouldn't recognize paying for telemedicine at that period of time. Quite candidly, the AMA was against telemedicine. Now, of course, they're big supporters of telemedicine, but they were against telemedicine. They blocked legislation that we had in Congress to get rid of state boundaries from the standpoint of medical licensure. We were following the route of banking legislation. And we were all set to go. And within 2 weeks of introducing the legislation to allow a physician in one state who is licensed to practice in any other state, given the fact that every physician in the United States to be licensed, have to take 3 exams, 3 national board exams. They're the same national board exams in every state. It's the only way you get a license. And yet, all of a sudden, you had to get a license in every state. We had a very simple rule to get rid of the state-by-state licensure. The definition of where the practice of medicine occurs is today defined by the location of the patient.
Yep.
Now, most of the time, patient comes to the doctor's office, so that's it. But if we simply change the definition of where the practice of medicine occurs to the location of the doctor, it solves the whole problem. But the AMA fought against it. But as soon as reimbursement occurred, the AMA was totally in favor of telemedicine.
And then to your point, the pandemic, which there was the 1135 waivers and the personal health emergency and, you know, and the licensure stuff. I mean, all that stuff started opening up, right? So you could go across boundaries and stuff. Where I'm getting excited is that pharmacists now in 35 states have the ability to be provider status, and I hope that opens up too. as well. But one thing I wanted to go into really quickly, and I want to point it out, Arlene, you're not necessarily concentrating on healthcare. You're a wireless person, right? And working with senior. I want to go through really quickly, and Jay and Arlene, you can give me a definition of what is the difference between telemedicine, telehealth, and remote patient monitoring? Because every time I turn around, and I actually did it on this program as well, I used a lot of it interchangeably. Now, I'm going to take your end result and give it away right now. That in the future, I'm hoping that 3 years from now, 5 years from now, we just call it healthcare, right? And stop coming up with these names for it. But what do you consider the difference between telemedicine and telehealth?
Who are you asking?
You, right? You. Since you're the father of telemedicine,
Yeah, well,
I'll get it from you.
First of all, the reason there is this transition from telemedicine to telehealth is the fact that the nursing profession was the first to say, listen, why are we calling it telemedicine? We're involved. And my NSF grant, I started the first nurse practitioner program in the state of Florida. And I compared nurse practitioners using telemedicine versus board certified internists physically on site at the location. That was my control. And what we found after a 3-year study was that nurse practitioners using telemedicine were equal to, if not in some areas better than, my board certified internists physically on site. So I've always been a supporter of the nursing profession. They got me through my internship, quite candidly.
Right.
So I never understood why the difference, but I really didn't care. If you want to call the whole thing under an umbrella term telehealth, that's fine with me. I really don't see any distinction between the two.
Yeah, I kind of nuance it a little bit and say telemedicine is two doctors point to point, peer to peer, right, and doing observations. Telehealth is between a patient and potentially a doctor, like a Teledoc or MD Live or other ones that are out there. And then remote patient monitoring is vital signs and other stuff coming in from the patient into the cloud some way to be reviewed either through AI or through a doctor, right? From that, those are just loose definitions I kind of framework within.
I think the new term that everybody seems to be using, digital health, probably covers it all. For us, it covers the remote patient monitoring, it covers the physician to physician, it covers the physician to the patient, etc.
Yeah, come on, it's now progressed on from digital health to virtual care and mobile care and virtual first and all that stuff as well. Arlene, let's talk a little bit about, I want to talk about, you starting Jitterbug. Where did that come from? And by the way, I want to ask one question first. The chicken and the egg scenario. Did you marry a person that invented the cell phone, or were you already married to the person that invented the cell phone, right? That's out there. Which one came first, the cell phone or Martin Cooper with you?
Oh, he made that first phone call about 6 years before I met him.
Okay.
Oh, I
So
didn't know
that work was already in progress.
The romance or the cell phone?
It was in the late 70s, right? In the late 70s. In 1983, cellular started, and we went on to do things that had to do with managing cellular companies. That's what I excelled at my company's business. One of the things we did is we figured out how to market and multiply the distribution in our markets, and that was very early on. That was called resale. It's now called resale. Believing that there were other people in the market could do a better job of serving people in their neighborhood. It was very advanced thinking at the time. And we really figured out how to use computers to operate the management of the business. And those things went on into what became a cellular operation, billing, et cetera, et cetera. And I moved on to build some devices that were connected. The first connected device that I had built, Motorola and Oki built those devices. They were credit card telephones that could be installed in public vehicles. And back in the, this was in the late 80s, and you could install these telephones and then the billing would work, using your credit card. And I won't describe to you how we did that, but
and our viewers may not know they had something similar in airplanes too for quite a while, where you could actually. Yeah.
That was the Airphone, and that happened possibly a little later.
Yeah.
But the thing that we did was in the late 80s. And that went on. By the way, in my paging business, just to back up for a minute, in my paging business, we did the first consumer wireless application. And that had to do with who was using pagers. And we actually went out and targeted people that had been identified for organ transplants. And we set up a pro bono program. This was for the public relations of the industry, which really wasn't industry then, but it was important to us to serve the people who were both supporting and who were waiting to receive transplants. Because you can imagine back then, what do you do if you're on the transplant list and you can't get that call when it comes? So we stocked the family and the organ recipient with pagers. So that was really the first incident of focusing in on a specific health need, something that health had set up in our lives, because organ transplants were just becoming possible.
Mm-hmm.
Lung transplants, kidney transplants, heart transplants, I don't think were there yet, but it was a big deal to be on the transplant list, and you just didn't want to miss that call. So when you roll forward, the Jitterbug effort really started back in the 90s when I started a company called SOS Wireless. And that company was building emergency phones that were primarily adopted by seniors.
Mm.
And that was a really rocky road that you can imagine back in the 90s. Resale by the cellular carriers was sort of you just didn't do it. If you had a voice application and you were wanting to get on the networks to provide a voice service to people, the carriers really had a hard time letting you do that, because that was their business. And so we had a rocky road until about 2004, when it seemed about the time with technology and handsets getting small and more difficult to use, more functionality and whatever, that not only was the market for simplicity and safety targeted at seniors had to be dealt with. And that's what really started that process. And so the idea was, we have to build a device that's unique. We have to build a service that's unique. We have to support our customers from stem to stern. There is no option. We're not going to automate everything. And so when we finally went into business with Great Call, I had actually bought a cellular carrier. And that cellular carrier provided a home base for all the phones that we sold for the first 3 years, maybe 4, maybe 5, that allowed us to get on the big carriers' networks and all of the little carriers' networks without those carriers knowing what we were doing. It was kind of a subterfuge. It really wasn't a subterfuge. We never tried to hide what we were doing. We just went about our business, and our business was to serve those people and to serve our customers who were either technophobes or infirm in other ways, and they needed to have service too. And this was a way to serve them.
So you were also bucking a trend when devices were getting smaller, and eventually the iPhone came around, and from that as well, some years down the road, 2007, 2008 timeframe. Yeah, people still wanted, seniors potentially still wanted to have flip phones, but the industry really didn't want to make flip phones out there. But because of your pedigree and Marty's pedigree, I think you told me at one time that somebody stepped up and very specifically for you decided to make your phones.
Yeah, Samsung did that for us in one meeting. Actually, we were there in Korea and came home and went back and showed them models of what we thought needed to be done. And of course, the fellow that was running Samsung's communications division was a character to start with. He was a real character. And he looked at it and he got it. You know, he took his glasses off and put them back on again. You know, he's probably having trouble seeing his own phones. So he knew what we were trying to do. And since we had that license, that cellular license, they could treat us like a real customer, not some MVNO, mobile virtual network operator who had some wild idea. No, I had a carrier, and he loved that. So they went ahead and built those phones for us. And what was important about that when we started was that was, if you go back and look at the slide decks of the roadmap that we had planned for seniors to be able to enjoy, you would get that in the New York Minute. No explanation whatsoever. We planned all these services, not just healthcare, but other ways. And we didn't intend, at least I didn't intend, to provide all those services. All I wanted to do is make sure that they got to the customer. And in the meantime, if somebody had a really good way of doing some medical sensors or whatever, because sensors were starting, the digital standards were starting to solidify. It was clear that what's happened was on its way before others realized it. So there was a long roadmap of services that we had that never got done, just because the execution of the business was selling cell phones.
Yeah.
Well,
I'm going to come back to you in just a second because I want to ask Jay a question. But, you know, it all comes down to market timing too, right? You know, from that perspective. And I want to come back to you and ask you about, you know, the PERS industry and the independent living industry and the seniors. And it seems like a lot of people are trying to acquire and bundle remote care around it, but they're going from the healthcare side instead of the consumer side to really understand what the consumer wants. But I want to let you think about that for a second and go back and come to Jay. Jay, you just wrote a book, right? That's out there with Michael, is it Gordon?
Michael
Right.
Gordon, yes.
Yeah. And he was one of the founders of Teladoc. So tell us a little bit about the book you wrote and why all of a sudden you're writing a book out there, which is phenomenal, by the way, but tell us a little bit about it.
Well, the only reason it got written was that Michael forced me to do it.
Oh, okay.
and I say that lovingly. In terms of Michael, I'm so glad that he got me to do it because I don't like to write. I like to give presentations, but I don't like to write. But fundamentally, what the book does is it goes from where we started at the beginning in the late 1960s, 1969 at the MGH, to where we need to go tomorrow. And it goes through the years that I developed, got my National Science Foundation grant in the early 70s, my invitation from the Shah of Iran and from President and Mrs. Marcos in 1976, to 15 years later, because I couldn't get anybody else interested in telemedicine, to when I got a call from the governor of the state of Georgia in 1991, October of 1991, to come up to the state to set up the 59-site hospital system in the state of Georgia, which became, for good or for bad, it became the model for the rest of the country. Arizona, California, and North Carolina all came down and modeled their program after that, and then it really became the model for the rest of the states. But during that period of time, I was also not only, we now had the capability to bring the expertise digitally from the academic medical centers to the rural hospitals. But the thing that I was very concerned about was why was I seeing the same patient in the ERs in those rural hospitals? So I got some federal dollars and some DOD dollars, and we developed the first technology to go into the home. And what was the technology that we had in 1995? It's called the TV. But unfortunately, what was in the ground connecting the TV to the TV station? Not fiber, coaxial cable. However, the local cable company heard about what we wanted to do, called me and said, look, we can convert the coaxial cable to a two-way system for you if you would like. It requires very simply a reverse amplifier, taking it through the message through an Ethernet bridge, and we have connectivity. They said the only problem is everybody who will be on the system will be on a party line. But we wanted to test the system to see if it worked. We picked out 20 patients to try the system on, and I'll never forget this. I'll never forget the first patient we saw on the system. They were at home. We were able to examine them in their home over their TV. And the first patient I saw was a patient with chronic asthma who was constantly being readmitted to the hospital about every 3 weeks. We could never figure out why. She had normal pulmonary functions when we sent her out of the hospital, and she'd go downhill the minute she left the hospital. Why was that happening? When I saw her at home, she was sitting in a great big puffy chair. She had her pet cat in her lap, and her husband was watching this whole interaction at the kitchen door with a cigarette in his mouth.
Awesome.
I then realized why my patient was being readmitted, but more importantly, it dawned on me that the best exam room is where the patient lives, not where the doctor works. So that was the first telehome care remote patient monitoring system in 1995. We called it the electronic house call. Of course, we've become much more sophisticated now, thank goodness. but I still think our original impression of the best exam room being where the patient is, not where the doctor is, still holds true. And we have the technology today to do that.
So right now I'm kind of looking up some stats and they're kind of all over the place, but digital health worldwide is estimated to be over $220 billion per year and growing. When you guys started it back in, the late 70s and into the 80s, it was zero. So how much of that percentage did you guys influence of $220 billion per year with your insights in wireless technology? And you guys must be gazillionaires, right? Because of that, right?
Yeah. Well, I'm still an academician, so you can
Okay.
you can figure out what that means in terms of my net worth. But the fundamental reality is that it took much too long for people
I
to
agree.
accept the reality of this. If I had to point, if I was asked to point the single finger, it would be the federal government.
Yeah.
Because they are the ones, and subsequently the insurance companies, who refuse to reimburse the physician for doing what I consider to be much better care, keeping the patient out of the hospital by doing telemedicine and making sure they're taking their medications and catching them at the earliest stage before they go downhill and require an emergency room admission. Preventative health care needs to be paid for. We can't wait until the patient gets sick to pay for their care.
Yeah, I won't name the agency that's out there, but there was a recent submission that was saying they wanted to connect with people and patients at home, but the device had to have POTS capability, right? Today,
POTS?
2023.
Unbelievable.
Yeah, right. Phone line. So why, right? Is that when wireless is prevalent, Wi-Fi is prevalent, right, out there? So you can say that potentially, in rural areas, they need to be able to connect with people, but you're going to limit the whole system on maybe 4 or 5% of the people that have some challenges in connecting. I was going to tell you something really, really quickly, and then I want to go back to, to Arlene, and then we're going to wrap up here in a little bit. But I'm hoping it's okay. We'll go a little bit longer with you guys because people are excited to hear from you. But we had an exciting project here in Arizona where we were approached by the Navajo Indian reservation. And they said, we want to actually connect with tribal members. But one thing, they live in a canyon up north, right, in the Grand Canyon. They have no electricity. Their caregivers are in Window Rock or Page, Arizona, 60 miles away, and there's no cellular connectivity with it. But we want to get the readings on a regular basis, right, to the caregivers. So we worked with a company here in Arizona called Space Data Corporation, and Space Data Corporation created balloons. So you see all the balloons they shoot down around, but they created balloons that they released above the canyon every single day. And it had a little box on it to create cellular spectrum. And we made our little IoT device plug into a car charger that would take all the data that came in from it and send it through the cellular spectrum that was created for an hour or 2 hours per day and send it to Window Rock, right? To that. We did one other thing. We put the voice of Peterson Za on there that spoke in Navajo to them, right? So it would go through and say your blood pressure is, and it would do it in Navajo, right? And it was incredibly, incredibly fun to do. But we're like, if we can do that, do anything, right? That's out there with connected technology.
When the state of Arizona developed their system, I became a consultant to the Navajo Nation, and one of the T1 lines went to the Navajo medical care station in Arizona. And I hope when you put up those balloons, they were not made in China, right?
I don't believe so. It was Space Data Corporation did. The interesting thing about it, and I don't want to get off on a tangent, is they would release them every single day, and then they would come down someplace in Texas or Louisiana. And I'm like, don't you have to notify the FAA? No, they're fine. We don't have to do that. And they could come down in the middle of a highway or a pasture or a shopping center. They just came down wherever they wanted to come down. And I'm like,
Wow.
thank God that's not my model, right? It's out there, right? But Arlene, let's go back to a little bit about Great Call and the reason why you started Great Call. I know Great Call is owned by Best Buy Health right now, but what was your bigger vision for a Great Call to engage seniors to be able to live more independently longer, right? From that, your thoughts around it.
Yeah, the original idea was to build on the platform of voice services that supported seniors' safety and health. There, like I said, our roadmap was pretty long, what we expected to do, not just our company, but the idea was to create a platform where the services, the access to the cellular networks was available, and it was available because it was our network, and that the services that we created, which included billing and operator assistance and things that would help seniors enjoy their services, could then be leveraged into a whole variety. And there's been a little of that at Great Call, but certainly not what I had expected. The idea being that if you provide telephone service or wireless services, and a lot of the services are going to become disconnected, they're going to become sensors and other devices. Those companies that build those technologies may not be planning or able to execute the distribution and marketing and support that it takes. So the idea is they could partner with us and bring their product to market. It might be a diabetes sensor. I mean, we knew all this stuff was coming. So it would allow it would create a marketplace. And in my thinking, this was a marketplace that was completely focused on the lifestyles of people who were in our market. And our market was typically 60 plus, 70 plus in that area. People that were still viable, they were moving around, but they did not like having to access all of their information, et cetera, through the methods that are built for 18 to 35-year-old males, which is what most of the technology, the target of most technology. So that was my dream, to create a place where these other companies could come and have no difficulty getting themselves to market, because there weren't the impedances that they had if they had to work for the carriers.
Yeah, I think that, one of the things, it's interesting, when my mom and dad were in rural Iowa and they started having issues from that, we needed to be connected to them 1,500 miles away. One of the first things we did was, assess the situation and put them with, a jitterbug device, right, that's out there, but also one that had PERS capability. So people don't know,
Right.
personal emergency response capability. There's a lot of PERS companies that are out there, and I always talk about static PERS and PERS where you had to wear a plastic pendant and talk to something 20 feet away, and if you're lucky enough to have your heart attack within 20 feet, then you're fine. Then it went into mobile PERS, right, from that. And I really think a lot of that's transitioning to what I call intelligent PERS, because we're finding that people will wear these PERS devices, but they won't push the button because they're afraid it's going to bring all these ambulances around and everything else with it, and they're going to get in trouble with their son and daughter. You've got to, where I think you're brilliant with this, you've got to start transitioning that from an emergency system to more of a concierge system, right? From that, and start meeting the needs of individuals. When we gave it to our parents, my parents said, that's great, I've got a connection device to somebody in case I fall or I need to talk to somebody easier. But what about all my other things, you know, food and connected devices and monitoring and living independently and non-emergency transportation? That's where I think it's going now with the hospital at home initiatives, right, that are out there. You're just ahead of your time in some regards, but the hospital at home initiatives require that anything that's in a hospital room needs to be replicated at home. And that includes calling to the nurse call center to be able to med reconciliation, vital signs, non-emergency transportation. So they're starting to build these trillion-dollar models now around community-based care that need to have your connectivity thoughts to be able to transition care safely. And that's the key word, safely to home, right, with it.
Yeah, the home care market is, and the way to serve people in their homes is really complicated in my view. I think, you know, we've been working on a device. I think I've told you a little bit about it, Kent.
Mhm.
We've been working on a device for a long time, not even beginning to touch anything that has to do with health, just trying to make a service that solves a problem for the target market. That's older people. And if you can get your device in the home, solving a problem for that market, then if you can create trust with those folks in their home, then you can start building on it. It's very much the same that happened with, forgetting about whether this is appropriate for our markets, but you know, you think about what Apple did. They started with their iPod, and it just kind of evolved into the cell phone and iCloud and whatever. And all of that became just a big bucket of stuff to put in, uncurated. And my view is that what we need to be doing with seniors is trying to coalesce the attachment of the devices that are used in their home and other places so that they don't have to deal with a whole variety of services and stuff.
Yeah.
And so that's what we've been working on for a while, but not even beginning to try to figure out how to solve some of the more engagement-based problems that need to be solved when you go into someone's home.
Yeah.
And maybe with AI here, there's going to be a big explosion of controls that people understand. And that might really be the key to turning on services for people, where they can just be very normal about how they're describing what they want. And by God, the market, the technology delivers it.
On a single integrated, curated platform,
Exactly.
without having 200 different vendors that are highly personalized to you.
Yeah.
Right.
Yeah.
So anyway,
so the service that I was starting had nothing to do with health. But you got to start someplace. And with the Jitterbug phone, we started with make it simple, be helpful, take care of your customers. And that included the billing.
Right.
We don't want our customers to suffer the frustration of all of these things that other people, younger people, deal with and don't mind. And by the way, I'll tell you from just going back to the beginning, everybody who is 30 years old and a tech person thinks that they will never become that person. Trust me, they will.
Yeah.
Someday that tech is going to be moving like a freight, like a speed train. And they're going to say, just stop. I want to get off. I just want my life to be around what I'm used to.
Yeah.
So,
And I think that's where we're at a little bit in time with AI, right? From that as well. But I was gonna say really quickly before we start wrapping up, I want to go back to Jay for a second. I don't want to disagree with my idol, you, right? But part of it is, I think, by you going through and putting tools together for independence, to allowing people to live independently at home, has a lot to do with health, has a lot to do with behavioral health. I've seen too many people that have not been able to live independently with tools, or the families to have tools, and they go into assisted living or independent living way too soon, and their health deteriorates. So you've done everything to try to elongate independence, which is everything about health, right, from that. So we in the industry, thank you for that, right, for what you and Marty have put together, right? You've done a big service to the industry, right? So Jay, just to kind of wrap up really quickly, one point you talked about, you started doing AI back in 1969. So what? How were you doing AI back in 1969?
It was predominantly machine learning. I don't think we have the time to do it, but it was after I was providing a discussion to the third-year residents who on a weekly basis would present me an unknown case from the hospital, and I would discuss it. I finished this discussion, and all of a sudden, I get a tap on my back. I turn around. It's my professor of medicine, Dr. Octo Barnett, who is actually known as the father of bioinformatics in medicine. And he said, Jay, that was a very nice discussion, but you know what? You could be replaced by a computer. That was 1969. And he got me started working on a branch logic tree. And I was just doing it to prove him totally wrong. And I'll never forget the first patient we tried it on. It was a patient who came into the ER, didn't look well. I asked him to sit down in front of our branch logic tree. 20 minutes later, the branch logic tree identified his disease as the very rare disease in medicine. It's called TTP, thrombotic thrombocytopenic purpura. And I was sure that that had to be totally wrong. And I called up Dr. Barnett and I said, Dr. Barnett, look what your computer program said this patient has. I started laughing. And he said, oh, that's interesting. 3 days later, the path report came back TTP.
Wow.
And I was a completely converted. But let me mention one last thing. We've been talking a lot about telemedicine and telecommunications. And Arlene, I apologize for what I'm about to say now, but the most important thing in telemedicine has nothing to do with telecommunications. It has totally to do with the message. If my physician consultant gives the wrong message and is out of date, it doesn't matter how great my telecommunication infrastructure is that provided that message. It's the wrong message, it's the wrong care. And unfortunately, everybody is forgetting the Institute of Medicine, it's now called the National Academy of Medicine, study that was done in 1999 called To Err is Human. And in that study, they clearly demonstrated that we physicians, underline, we physicians kill 98,000 people a year on average from inadvertent medical errors. And that study was repeated in the British Medical Journal by Johns Hopkins in 2015, increasing that number. So the real point is, the reason that AI is so critical to me is that AI will replace the single physician at the bedside with collective expertise. And that's why AI to me is going to be so important and so dramatic. And the sensor work, and by the way, once again, 1969, I was introduced to the radar technician who developed the Health I'm Falling pendant, the initial Health I'm Falling pendant. And he said, do you think this is going to be of any value in healthcare? I said, gee, with this pendant, if we could get mean arterial blood pressure as well, because it's right over the heart, that would be fantastic. We now have the capability to do that. So a combination of telemedicine, telecommunications, AI, and medical sensors, just like your car dashboard, you don't know anything about it until a red light goes off, will be the healthcare delivery system of tomorrow.
That's awesome. So we need to wrap up, but I want to go through and just say, Jay, thank you so much for, all you've done for the industry as well. Well recognized as, as from ATA recently, as well as the father of telemedicine, right, from that, and well deserved from it. So really quickly, just within a short time frame, what's exciting you, Arlene, that's out there as far as technology that's coming on the market, coming next? And Jay, think about it as well for you. In the wireless world, did we invent everything from a sensor perspective already? Miniaturization, disappearables, right?
Yeah, well, I'd have to parrot Marty's comments. He thinks that we're going to have embedded embedded stuff that's going to help us live better lives because it's connected and delivering information.
Don't you think these things that are sitting on top of our face, are going to be incredibly intelligent in the future? Or maybe they go away. I don't know.
Could do a lot more, but I think part of the issue is that I think we still are in a mess of technology.
Yeah.
And I think it's very hard for loved ones to serve their senior relatives. I think it's too hard to adopt. The adoption of the technologies that we now have is the problem. The methods that are being used and the chaos in the market over getting things done. There's such a flux, so many things that we can try to adopt. And I think that the volume of things that you're going to end up having to adopt and learn and understand and triage and all of that is just out of control.
Yeah.
So I'm hopeful that whether it's us in the project I've been working on or someone else, they need to figure out how to make adopting good technical support in the home and for people on the road easy to engage and to adopt and engage with.
I think we've talked about this before, but I've always had the concept of something called indie living, which is just sitting on the side of a Best Buy and you're not bringing one lick of new technology in. You're just marketing and connecting things differently. You're just connecting to an audience differently that's out there instead of it, but you're selling out of the same warehouses, right? Jay, what's exciting you? What's exciting you?
Well, quite candidly, from my standpoint, the healthcare delivery system begins when you're born. What will happen in the future, from my prediction standpoint, is everybody forgets when they're born. They don't realize this. They have a blood test taken from their heel of their foot for enzyme abnormalities, the first one being phenylketonuria. Well, in the future, that same blood test will be used to obtain your genetics. Your genetics will dictate the kind of sensors you will wear. You will wear them. They will, as Marty has said, they may be embedded. They, in fact, may be less than 7 microns, and therefore they will be circulating in your blood. The home builders, the ADTs, and the alarm.coms will build the homes and the condominiums that have all the physiological sensors when you're in the home. When you're outside, your watch, your glasses, using AR and VR, will be assessing your capabilities. You will be literally connected to the cloud with all your sensors, and the only time a sensor will go off when by your genetics, when by your epigenetics environment in which you're in, when something goes wrong, you will be alerted to it. In the same way, everybody forgets this. When you get in your car and you push the ignition button, what happens? The dashboard lights up. You know everything about the car, and the only time you worry about anything is if a red light goes off on that dashboard. Guess what? The car of the future will have a medical dashboard. When I sit in the car, I've got my weight. When I put my hands on the steering wheel, I've got my pulse, my rhythm strip, my RR variability, my pulse oximetry, my temperature. When I take my seatbelt and I plug it in, I've got my respiratory rate, my respiratory volume, and my mean arterial blood pressure. There's going to be a medical dashboard. We will then transition to have that medical dashboard in the home, connected to the Alexas of this world, which will immediately identify when I'm having a problem that I'm not even aware of. That's going to be the home of the future.
I'm not too keen about the car being that intelligent, because as I drive through McDonald's and do my pre-dinner meal before I go home, right?
They won't let you drive into McDonald's.
I know, I get it, I understand it. So anyway, I want to thank, both the, Dr. Saunders and Professor Harris, right? I'm going to give you a degree right out there. You certainly, deserve it, right? But both thank Jay and Arlene for participating, your great insights. And you can find the details of our upcoming episodes and access today's recording and video on our popular podcast sites, streaming sites, services, and on our website, www.newnormal.buzz. But again, you guys are considered old friends, and colleagues, and I love you both. And
Long-time friends.
There you go.
Long time
Well,
friends.
I meant with me too. You guys are longtime friends, but I consider you I consider you personal friends, and thank you both for taking time of your day to share with the audience. I really, truly appreciate it.
Please give
It's
Marty
been
a
a
hug for
pleasure.
me.
It's been a pleasure.
Thanks, guys. Have a good day.